Good morning, guys, and welcome to week 10. This is exciting. After this week, we only have 4 new weeks of new material, and then we're looking at the final exam. So we are getting there. This week, we're going to talk about the muscular system. Hopefully, you've all recovered from our muscle physiology lecture from last week. So before we learn the individual muscles, we are going to learn how to classify different types of skeletal muscle. So we classify them by the way the fascicles are organized. Remember, the fascicles are bundles of individual muscle fibers, and by the relationship that those fascicles have to the tendon. So they don't all come straight off the tendon. They can go off at angles. So we're going to learn about all that. So we have 4 patterns of fascicle arrangement: parallel, convergent, pennate, and circular. Our parallel muscles are just what they sound. It's where the fascicles are parallel to the tendon. So here we have the tendon and then the muscle. So the tendon is going straight up and down like this to connect into the bone, which would be down here. And then the fascicles are parallel, just like that, to the tendon. So they're parallel to the long axis of the muscle. The biceps brachii is an example of a parallel muscle. And if you look at this muscle in cross section over here, you can see that when you cut directly across the muscle, you see the individual cross sections of the fascicles, and within the fascicles, you see the individual muscle fibers that are all cut in cross section. Convergent muscles are a broad muscle that has multiple fascicles which are going to converge together onto the tendon. So here we can see that there's a fascicle here. Oh, let me change that color. So this one's coming down this way, this one's coming straight across, this one's coming up like that. So you have all these individual fascicles, but they're all converging upon the tendon. They can converge on a tendon, on an aponeurosis, which if you remember is a sheet-like tendon, or on a raphe. That's a new word for us, a raphe, which is a ridge or a seam in a muscle or an organ. The cool thing about these fibers is that they can, when they contract, they pull in different directions. So you could contract the top of this muscle and pull the muscle this way. Or you could contract the bottom of this muscle and pull that way. Or you could contract the center and pull straight back. So you can really, there's some flexibility in these muscles with how they are functioning and what result they're going to have depending on what part of the muscle is actually firing. The pectoralis muscle is an example of a convergent muscle. And so you can, you have the upper part of your pecs, the middle part, and the lower part, and contraction of each individual part is going to affect your shoulder differently. Pennate muscles have fascicles that form an angle to the tendon. So here you can see the tendon is going straight up and down, but then the fascicles go off at an angle. So if this was a parallel muscle, the fascicles would go straight up and be parallel with the tendon. But in a pennate muscle, the fascicles go off at an angle from the tendon. They don't move as far as parallel muscles because it's less efficient to pull on an angle from the tendon. They contain more myofibrils than parallel muscles, so they can develop more tension. Even though they don't move as far, they can develop more tension. An example here would be extensor digitorum muscle. We're going to learn about that later this morning, but the muscles that are all moving your fingers are in your forearm, and they are traditionally pennate muscles. So this one is called a unipennate muscle. Let's see. Here's unipennate, which means that there is one single bundle of muscle fibers coming off of this tendon. So there we go. Unipennate, fibers on one side of the tendon, so the extensor digitorum is a unipennate muscle. Bipennate means there's fibers on both sides of the tendon. So the rectus femoris is an example of a bipennate muscle. So the tendon, we see the tendon here, but then that tendon also runs straight up the middle like that. So then you can see that the muscle fibers are coming off of that tendon at an angle. Multipennate are have tendons that branch within the muscle. So the deltoid is an example. So if this is the deltoid muscle, then it's covering your shoulder is right under here, and then this is going down the length of your arm towards your elbow would be down here. So this muscle has three different sections. So it has a posterior section, a lateral section, and an anterior section. So if you look over on this picture, you can see that in cross section, you have a tendon in the center of each of those pieces of muscle. You can also, like the convergent muscle, you could contract one of these muscles. So if you just contracted this muscle, you would be pulling the arm forward. If you contracted this muscle, you would pull the arm backward. And if you contracted this muscle, you would pull the arm up. So you would abduct that arm away from the body. Circular muscles are exactly what they sound. They have fascicles that are arranged in a circle. We also call them sphincters, and they open and close to guard entrances of the body. So the orbicularis oris here is a muscle that wraps around the mouth and allows you to open your mouth and close your mouth. So they are wider when they're relaxed, and they are smaller when they are contracted. We also have the orbicularis oculi, which looks very similar, and it wraps around your eye so that when it's relaxed, your eye is open, and when it's contracted, your eye is closed. We're going to do a small lesson in physics here. I don't want you to spend a lot of time memorizing all of this, but there's a couple of things that I'll point out that I think are important. So we're going to talk about levers, and a lever is a bone. So the bone would be the lever, and that's a rigid moving structure. So bones are rigid and they move when muscles pull on them. The joints are considered the fulcrum. So a fulcrum is a fixed point around which a lever can move. Oh. All right, sorry about that. That was an accidental going forward, and it appears I cannot go back. So to finish the last slide, the muscles provide an applied force, which means that they are pulling on the bone to move the bone around the joint, or in other words, to move the lever around the fulcrum. And the applied force that the muscle is producing is required to overcome resistance, and that resistance is considered the load. So the load could be a body part, like if you're trying to flex your biceps and bring your forearm up towards your shoulder, then the load there would be your forearm from your elbow down. You're trying to bring that weight up towards your shoulder. If you have a 25-pound weight in your hand, then that would be a much greater load that you have to overcome in order to pull that weight up towards your shoulder. And we have three different classes of levers. So the first class lever is like a seesaw. So you have the fulcrum in between the load and the applied force. So if we're looking here, here's the fulcrum. So the fulcrum would be the joint. And then the load is the weight coming down in front of the fulcrum, and the applied force is pulling down opposite the load. So if you picture here, you've got this kid going down and trying to lift up the weight of that kid. So in our example over here, we have the head, and the fulcrum is the atlanto-occipital joint, so between C1 and the occiput. The load is the weight of the head, so you can see that this head is pretty big in comparison to the muscles in the back, but we don't want our heads to fall forward all the time. So instead we have an applied force, which is the pulling of the muscles in the posterior neck, and they are offsetting the weight of the head so that you can keep your head upright. So the applied force is working against the load, and it works against it because it's pulling on the back of the head to pull the head up versus the load, which is trying to pull the head down. Second class levers are like a wheelbarrow. So you have the load in the center between the applied force and the fulcrum. So the lower leg is an example here. You've got the fulcrum being those metatarsophalangeal joints right in through here. And then the load is the weight of the body coming straight down onto the talus. And the applied force is the gastroc and soleus, the muscles in the posterior leg, which are pulling up and trying to overcome the load. So the applied force and the load are going in opposite directions, and the force is overcoming the load in order to pivot your body over the metatarsophalangeal joints. A third class lever is the most common lever in the body. That's something that I would probably know. The applied force is in between the fulcrum and the load, and the elbow is a great example of this. So if we're looking at the elbow, the fulcrum is in the back. It is where the ulna and the humerus come together. That would be our fulcrum. The applied force is the biceps. And this is where it's important to consider the attachment and not just the muscle, because a lot of people think that the biceps might be behind the elbow or even with the elbow, but the attachment of the biceps is at that radial tuberosity. And so when the biceps is contracting, it's pulling on the radius to bring the forearm up toward the shoulder. So the load is either the weight of the arm or it's whatever you're holding in your hand. So if you're holding a 25-pound weight, that becomes the load plus the weight of your arm. Otherwise, it could just be bringing the weight of your arm up. So that's a third class lever, and that's our most common lever in the body. All right, so we're going to start to get into the actual muscles. So muscles have 2 points of attachment. They have to attach to 2 different bones, and in order for them to be functional. The origin is the fixed point. So that's the point that does not move. And the insertion is a moving point. So anytime a muscle contracts, we're wanting something to move. So the part that moves is the insertion, and the part that does not move is the origin. Most muscles originate and insert on the skeleton, but not always. Some of them can insert on a tendon or a raphe, but for the most part, you can consider that they're going to originate and insert on the bone. And the origin is usually proximal to the insertion, but not always. So that's something that it's not like a strict rule of always, but it is usually the origin is typically proximal and the insertion is distal. Some terminology: the agonist is the prime mover. So the muscle that is the largest muscle making the change that you want is called the agonist. So if you're looking at the arm and you're trying to flex the forearm up toward the shoulder, then the biceps is your agonist. It's your main mover. The antagonist would be a muscle that opposes the movement that you're trying to make. So when you're looking at flexing the arm, the antagonist would extend the arm. So the antagonist in this situation would be the triceps. You see, triceps extends the arms. And then a synergist is a small muscle that assists the agonist. So it helps to start movement or stabilize the region in order for the agonist to move. So we have a few synergists in our body that we'll talk about. The main synergist that I like to talk about is the supraspinatus muscle. That's one of the rotator cuff muscles, and it aids in abduction of the arm, but it's a very small muscle, so it does the first 15 degrees of abduction or abduction of the arm, and then the deltoid takes over. These next two slides, I want you to take some time to really study. We can learn a lot about a muscle by the name of that muscle. And that's what I want you guys to come away with this week, is to understand these terms and be able to look at the name of a muscle and then kind of dissect that name to figure out, okay, where might that muscle be? Or what might that muscle do? Or how big might that muscle be? And all of these terms are what are going to tell you all of that information. So we're going to start up on over here. So the abdominis would be a muscle that is in the abdomen. That seems pretty easy. The abdomen is the stomach region. Anconeus is at the elbow. Auricularis would be at the ear. The auricle of the ear is that external portion of the ear that we can see, touch, and feel. Brachialis is the brachium, which would be the arm. Capitis means attached to the head. Carpi is the wrist. The wrists are the carpal bones, the carpal region. So anything that says carpi is in the wrist region. Cervicis is the neck. We know the neck is the cervical spine, so cervicis is the neck. Clido or clavius attaches to the clavicle. So we have a muscle called the sternocleidomastoid, and that attaches to the sternum, the clavicle, and the mastoid process. Coccygeus is in the coccygeal region around the coccyx. Costalis is the ribs, so attaching to the ribs. Cutaneous is either attaches into the skin or is very superficial. Femoris attaches into the femur or affects the femur. Genio is the chin, so anything attaching to the chin would be genio, like genioglossus. So here's the next one, is glossus or glossal attaches to the tongue. So you don't have to memorize all of the different muscles that attach to the tongue. You know that anything that ends in glossus attaches to the tongue. So there is a muscle called genioglossus, so you know just from vocabulary that that goes from the chin to the tongue. Hallucis is your great toe. Ilio attaches to your ilium. There's a few more of these on the next page, but we will wait because I can't go back apparently. So moving over to terms that indicate position, direction, or fascicle organization. So that's going to tell you like how does that, where is this in space, or how does it move? So anterior would be in the front. Externus is superficial, and these are going to have opposites. So anterior is versus posterior. So you can see posterior down here, anterior up here. So those are opposites. So anterior and posterior go together. Externus and internus go together. So externus means superficial, internus means deep. Extrinsic is on the outside, intrinsic is on the inside. So those two go together. Inferioris is inferior, and superioris is superior. Lateralis would be on the lateral side. Medialis is on the medial side. Oblique would be running in an oblique orientation. So that would be the fascicles arranged at about a 45-degree angle from other muscles that might run perpendicular to the body. Profundus is another word used for deep. Rectus is a straight parallel muscle. So we have rectus abdominis that goes straight up and down the middle of our abdomen. Superficialis is superficial. So superficialis and profundus are opposites. And then transversus goes across the body, sort of perpendicular to the long axis of the body. We have terms indicating the structural characteristics of the muscle. So the biceps, triceps, and quadriceps, those have 2 heads, 3 heads, and 4 heads. So our biceps brachii has 2 different heads or 2 different points of attachment, 2 origins. The triceps has 3 origins, and the quadriceps has 4 origins. The shape of the muscle can also be given away in the name. The deltoid is a triangle muscle. Orbicularis is orb, so that's a circular muscle. Pectinate is a comb-like muscle, and you'll see that when we look at the pec minor, it has multiple heads that look like the tines of a comb, or teeth on a comb. Piriformis is pear-shaped. Platy means flat. One of my favorite muscles is the platysma, which is a large flat muscle on the anterior surface of your neck. Pyramidal would be pyramid-shaped. Rhomboid would be shaped like a rhombus. Serratus is serrated, so that again also, like the pectinate, would have multiple origins or insertions. The splenius looks like a bandage. That one, I wouldn't probably memorize that one. Teres muscles are long and round. And then we have terms that indicate actions. So abductor or adductor are going to either abduct or adduct. Depressor brings things down. Extensor brings things, extends them. Flexor is going to flex or shorten. Levator is going to elevate. Pronator is going to pronate. Rotator is going to rotate, you guessed it. Supinator is going to supinate. And tensor is going to make tense, so pull on something. Some specific muscles, buccinator is like a trumpeter. You'll find the buccinator muscle in your cheeks. Risorius is a muscle of laughter. Sartorius is like a tailor. I wouldn't worry too much about those 3. So here's our specific body regions on the left-hand side. We're going to go over those a little bit more. So inguinal up here is in the groin. Lumborum is in the lumbar region. Nasalis is nasal or in the nose region. Nuchal is the back of the neck. And you can remember on the back of the occiput, we have the superior and inferior nuchal lines. So those are muscles from the back of the neck that are attaching up into the occiput. Oculo is in the eye. So we have orbicularis oculi is the round muscles surrounding the eye. Oris is around the mouth. Palpebrae is on the eyelid. So we have a levator palpebrae, which opens, lifts the eyelid. Pollicis is the thumb. Popliteus in the posterior knee. Psoas is in the loin. Radialis is on the radial side or of the forearm. Ulnaris would be on the ulnar side. That's down here. Scapularis attaches to the scapula. Temporalis attaches to the temples or the temporal bone. Thoracis is in the thoracic spine. Tibialis attaches to tibia. And then uro is muscles that attach into the urinary tract. And over here we can finish with terms indicating structural characteristics of the muscle. So trapezius is a trapezoid shape. Other striking features, alba is white. We also have brevis and longus. Brevis is short, longus is long. Gracilis means slender, like a long, slender muscle. Lata would be a wide muscle. Latissimus is the widest muscle. And then longissimus would be the longest muscle. Magnus is a large muscle versus minimus, which would be a smaller muscle. You can also say maximus and minimus. Minor is a small muscle as well versus major, which is a larger muscle. Tendinosus is a tendinous muscle. And then vastus is like a large muscle as well. So that's a lot of terminology for muscles, but if you can really get through this and commit some of these to memory, maybe do some flashcards with these, it'll go a long way with helping you learn the individual muscles that we're going to be going over. So the muscular system, much like the skeletal system, has axial muscles, which position the head in the spinal column, move the rib cage. Those account for 60% of our skeletal muscles. And then our appendicular muscles support the pectoral and pelvic girdles and support and move the limbs, and those account for 40% of our skeletal muscles. So we have some pretty pictures here that I would certainly use for studying. Right now I'm going to skip over them so I can do one individual muscle at a time. So come back and look at these on your own. All right, so we're going to start with our exploration of the axial muscles. So we have 6 muscle groups of the head and neck. We have muscles of facial expression, which all originate on the skull. Extrinsic eye muscles, which are muscles that affect the eye and control the position of the eye, but they originate on the surface of the orbit, so they're originating on the skull. Muscles of mastication. Mastication is chewing, so these are muscles that move the mandible. Muscles of the tongue, and this is what I want you to know about muscles of the tongue. They all end in glossus. So if you see a muscle and the name of it ends in glossus, you know it's a tongue muscle. Muscles of the pharynx. The pharynx is a passageway that allows air movement, but then it's a shared passageway between the respiratory system and the digestive system. So when you swallow, it also is for the passage of food, and the pharynx has to be lifted up by the muscles of the pharynx in order for the epiglottis to fold down and cover the glottis and keep your food from entering your respiratory system. And then we have anterior muscles of the neck, which control the position of the larynx, depress the mandible, which is the jaw, so opens the mouth, and then supports the tongue and the pharynx. Muscles of facial expression. The orbicularis oris, we do want to know that one, that constricts around the mouth. So you can see it in this picture. Maybe this doesn't work well. So it's right here, orbicularis oris. It's a circular muscle that goes around the mouth, and when it is contracted, your mouth is closed, and when it is relaxed, you can open your mouth. The buccinator muscle moves food around in your cheeks. So that is this muscle down here. You can see it there. That's the one that's called the trumpeter muscle. So if you play the trumpet, you use the buccinator muscle a lot. So right there. And then you also have muscles of the scalp. So we're going to look at those in the next slide. So our muscles of the scalp are, you don't have to memorize, they are named for the bones that they attach to. So temporoparietalis, which is here, attaches from the temporal bone up to the parietal bone. Occipitofrontalis attaches from the occipital bone to the frontal bone. That muscle is interesting because it has these frontal belly here, and then it has bellies like that on the occiput, but the in between those we have the epicranial aponeurosis, which is just a large sheet-like tendon that covers the top of the scalp. But contraction of the frontal belly of the occipitofrontalis is going to sort of pull the scalp forward, and contraction of the occipital portion is going to pull the scalp backward. And then this is one of my favorite muscles. You'll learn if I say it's my favorite that you should learn it. Oops. Sorry, kids. All right, so the platysma is this long flat muscle here that covers the anterior surface of your neck. And I usually do a really funny face to show you this in class, but you guys don't get the pleasure of that. So if you were to sort of jut out your chin, you can tense this muscle and make like a flattening of the anterior neck, and that is the platysma muscle. On this chart, the ones that I would want you to know are the buccinator, orbicularis oris. These two, depressor labii inferioris and levator labii superioris. Labii means lips. So this one is depressing the lips, so in like a frowning, and it is inferior to the mouth. Levator labii is elevating the lips, and it is superior to the mouth. So another example of how you can use the vocabulary that you know to figure out where that muscle is and what it's doing. Levator anguli oris is at the angle of the mouth. So that's your smiling muscle. And then depressor anguli oris is your frowning muscle. So you don't have to memorize those, but I want you to be able to look at the terms and figure out where they are and what they do. So the ones that I want you to memorize on this chart are the buccinator and the orbicularis oris. Around the eye, the levator palpebrae superioris elevates the eyelid or opens your eyes. Orbicularis oculi is the circular muscle around your eye that allows you to close your eye. The corrugator supercilii, I like this one because it's supercilly. It is right around the eyebrows, and it's what allows you to sort of wrinkle your eyebrows. So that one's a good one. Those are the main ones that I want you to know on this chart. We have 6 different extrinsic eye muscles. So those are muscles that are outside of the eye, but they are acting on the eye to move our eyes around. There are 4 rectus muscles and 2 oblique muscles. The rectus muscles are super easy because they do exactly what you would think that they do. So the superior rectus up here, you can see it here, attaches, it's above the eye, attaches to the top of the eye, and when it contracts, it moves the eye upward. So it makes you look up. Superior rectus on top makes you look up. The inferior rectus down here is on the bottom, and when it contracts, it makes you look down. So it's going to pull right here and force you to look down. The lateral rectus over here is on the lateral side, and when it contracts, it makes you turn your eye laterally. And the medial rectus is on the medial side, and when it contracts, it makes you turn your eye medially. So if you were to contract both of your medial rectus muscles, your eyes would be crossed. The 2 trickier ones are the oblique muscles. So we have a superior oblique and an inferior oblique. The inferior oblique muscle here attaches to the medial side of the eye and then wraps around to attach into the lateral side of the eye. So when that muscle contracts, it pulls the eye laterally and looking up. So if you picture, it's pulling this way from up here. So that's going to tilt your eye up. And then it's also pulling to create laterality or lateral movement. It's hard to show all of these on here. So the inferior oblique makes you look up and out, and your superior oblique, which is up here, the superior oblique is a really cool muscle. Actually, you can see it better on this side. So let's look on this side. So the superior oblique comes over the eye, and then it goes through this little ligamentous, it's like a ligament here that holds this tendon. And so it goes over that ligament and then comes down to attach into the top of the eye. So it pulls your eye down and laterally because of the way that it attaches. So inferior oblique makes you look up and out. Superior oblique makes you look down and out. All of the rectus muscles pull the way that they are named. So superior oblique pulls, or superior rectus pulls your eyes up superiorly, inferior rectus down, lateral rectus laterally, medial rectus medially. So here's just another picture of how those muscles attach into the eye. And then on this side over here, you're looking at the eye has been removed. This is the optic nerve in the back. And then you've got your rectus muscles. So here's your lateral, your medial, your inferior, and your superior rectus. And then over here is your superior oblique. And then down there is your inferior oblique. So you can see how those muscles are actually situated within the eye socket. So I do expect you to learn all 6 of these eye muscles. All right, next we have muscles of mastication. Remember, mastication is chewing. So these are muscles that assist in chewing and move your mandible. The masseter is the strongest jaw muscle. I would know that. That's a great fact. That's easy to know. The masseter is right here. So it is this muscle right there that goes from your zygomatic arch down to your chin. So when that contracts, it lifts your jaw. The temporalis muscle is right where you think it would be. It is on the temporal bone, and it actually comes down and comes underneath the zygomatic arch and attaches on that coronoid process of the mandible, and so it also helps to elevate your jaw. And then the pterygoid muscles, they help position the mandible for chewing, and we're going to look at those in the next slide. So here are the pterygoid muscles. I just wanted you to be able to see them. You don't have to memorize these, but they are muscles. So here you can see that the jaw has been cut away. So they come down from the maxilla and they attach into the inside of the mandible. And so they also help to position the mandible. The pterygoid muscles attach to the pterygoid plate of the skull down into the mandible. So on this one, you're going to learn masseter and temporalis, and I wouldn't really worry about the pterygoids. Muscles of the tongue we've talked about before. They all end in glossus. You can see that over here. So if it ends in glossus, it attaches to the tongue. The first part tells you where it originates. So the palatoglossus originates from the hard palate. The styloglossus originates from the styloid process of the temporal bone. The genioglossus we talked about earlier originates from the chin. The hyo is hyoid bone, so the hyoglossus originates at the hyoid bone and connects up into the tongue. So don't memorize any of those, but be able to look at those terms and understand the origin and attachment. Muscles of the pharynx. I'm not going to make you learn all of these. We have pharyngeal constrictors, laryngeal elevators, and then palatal muscles. So the one palatal muscle that I really like is tensor veli palatini. That attaches in the back of your throat, and when there's tension in that muscle, it can actually interfere with the draining of your middle ear. So chiropractically, I used to work on that muscle a lot in young kids who had repeated ear infections. They don't love it. You kind of gag them when you work on it. But if you can get that muscle to release and then also adjust the upper cervical spine to get the bones moving better, you can see how intricately connected all of these muscles are around the spine. So when the movement is better and that tensor veli palatini muscle is relaxed, it allows for better draining of the inner ear or the middle ear, and can sometimes keep kids away from having to get tubes. That said, my own kid ended up with tubes, so it's not 100% for everybody, but it's worth a try. All right, so again, these ones, tensor veli palatini, I'll have you learn that one, but I wouldn't necessarily worry too much about the rest. I apologize for the cat. She really wants to get in on this lecture, apparently. So anterior neck muscles, you can see are mainly small muscles that connect into the hyoid bone, which you can see here in the middle. So anything that attaches to the hyoid actually has hyoid as the end of it. So geniohyoid, we know genio is the chin, so it goes from the chin to the hyoid bone. Stylohyoid goes from the styloid process to the hyoid bone. Thyrohyoid goes from the thyroid cartilage to the hyoid bone. Sternothyroid goes from the sternum to the thyroid cartilage. The main one that I want you to know on this is the sternocleidomastoid. That's a very important muscle. You can actually see it better on this side. So it has three different attachments: the sternum for sterno, the clavicle for cleido, and the mastoid process of the temporal bone. So it is the sternocleidomastoid. When you constrict that muscle or tense that muscle, it flexes your head or flexes your neck and then rotates to the opposite side. Here we've got our cutaway. Here's our hyoid bone, and then we have our geniohyoid and our mylohyoid, which is mandible to the hyoid. I'm not going to test you on those, but you should be able to look at those and understand with just breaking down the vocabulary there. Genio we know is chin, hyoid is hyoid bone, so that's an easy one. So on this list, you're going to learn sternocleidomastoid. Everything else you should be able to kind of figure out, but that's the one that I really want you to know on this list. We are moving on to muscles of the vertebral column. So we have muscles that flex and muscles that extend. So the erector spinae muscles are the spinal extensors. We have superficial muscles closer to the skin and deeper muscles that are deep along the vertebral column. And then we have spinal flexors, which do the opposite, and they flex the spine. So we're going to look first at our superficial muscles. So these are not, they're larger muscles, and they act on larger regions of the spine. So we have the spinalis group. So here's our spinalis. And our spinalis muscles go from spinous process to spinous process. So they go straight up and down in the center. And so we have spinalis thoracis. So that's within the thoracic spine. Over here, spinalis cervicis in the cervical spine. So the spinalis is spinous process to spinous process. Longissimus is transverse process to transverse process. So those are laterally on either side, and they're also named for the region of the spine that they're in. Longissimus cervicis is going to attach into the cervical spine. Longissimus capitis is going to attach up into the head. And then our iliocostalis, anytime you see costa or costal, that means ribs. So our iliocostalis attach from our ribs into our transverse process. So here's our iliocostalis, and that's ribs to transverse process. You'll see some of these have multiple heads, so they might go up one vertebral level, 2 levels, 3 levels, 4 levels, so they can sort of move throughout the spine, and we're not going to have to memorize if they go 1, 2, or 3 levels, but just know that some of them are very short and then some of them are much longer. Now we have our deep spinal extensors. So our semispinalis and multifidus go from transverse process to spinous process. So our, let's see, we're not really showing those very well here, but they go from transverse process to spinous process. Our interspinalis muscle is between the spinous processes. So interspinalis here, so they go in between spinous processes, so they span one vertebrae, so spinous process to spinous process. Intertransversari muscles are going to be in between the transverse processes. So we can see the intertransversari up here where it's transverse process to transverse process. So again, those are one level muscles. Now, when you look at something like the intertransversari, if you are utilizing, let's do tensing both sides at the same time, that's going to aid in spinal extension. If you are only tensing one side, then that's going to result in lateral flexion. So if you were to tense just this muscle on the left, that would help to put the spine into left lateral flexion. And then last are rotatories muscles, which we see here. These are going on an angle from transverse process to spinous process. Some of them span one level, some of them span two levels, and when those bilaterally contract, it's going to extend the spine, and when they unilaterally contract, they're going to rotate the spine. All right, on this one, what I want you to know are which muscles are extensors. We're going to look at some of the flexors, but I just want you to know which muscles extend the spine and then which muscles flex the spine. I also should have pointed this out earlier that the innervation we are not doing. We have not learned any of the nerves yet, so learning the innervation before you learn the nervous system does not make sense. So please don't look at the innervation on any of these. And I don't want you to memorize like all of these, every single thing that every muscle does. So if you were to look at longissimus, you could know that there's portions that attach to the head, portions that attach to the neck, portions that attach to the thoracic spine, and they're all spinal extensors. That's the gist of what I want you to know. I will not ask you transverse process to mastoid process, all of that stuff. That's too much to ask you to memorize in 1 week, okay? So again, here we're looking at the spinal extensors. Now these are spinal flexors. So these are in the anterior part of the spine. So you can see that the skull is resected here to give us a better understanding of these anterior muscles. So we have longus capitis. So capitis is going to attach into the head. It's a long muscle, and you can see that it goes from the transverse processes up into the skull. Longus coli is another long muscle that is in the front of the neck. Those are spinal flexors. And then we have our scalene muscles. These are super important muscles, so I do want you to know those. There are 3 of them, anterior, middle, and posterior. That's the most of what you need to know. They go from the transverse process in the cervical spine down into these first 2 ribs. And you can feel them if you feel just above your clavicle, you can feel those 3 muscles right there. And so they are, when they're too tense, they can pull on your first rib, which can be painful, or they can actually press on some of the spinal nerves that are exiting the spinal cord here and cause pain that radiates down into your arm, which can actually mimic disc herniation. So that's something that you have to consider for a differential diagnosis when somebody has arm pain of how can you reproduce that pain. And the scalenes are going to create pain much differently than a disc herniation is going to create pain. So we have to know that there are always multiple ways to create similar pain. So on this one, we did these in the back. Those first ones are extensors, and then we're going to move to our spinal flexors. So just knowing that the longest muscles, capitis and coli, are spinal flexors. The quadratus lumborum is also a spinal flexor. That's in the lumbar spine. It goes from the iliac crest up to the 12th rib. And so when both of those are contracting, they flex the spine. When one is contracting, it's going to laterally flex the spine. We have oblique and rectus muscles within the body wall. So those are our abdominal muscles. Oblique muscles are on a 45-degree angle. They compress the underlying structures and help to rotate the vertebral column. The rectus muscles, like rectus abdominis, are going to oppose the erector spinae and flex the vertebral column. In the cervical region, our oblique muscles are the scalenes. When they are both sides are contracting, they flex the neck. When one side is contracting, they rotate and help to laterally flex. In the thoracic region, we have the intercostal muscles. So inter meaning between, costal is the ribs. You have external and internal intercostal muscles, and those actually help to elevate and depress your ribs during breathing. So the external intercostals bring your ribs up and open while you inhale, and then the internal intercostals bring your ribs down and close while you exhale. You don't have to memorize that. Just know that they are that they move the ribs and are muscles of respiration. And then the transversus thoracis is a transverse muscle that actually crosses the inner surface of the ribs. In the abdomen, we have the external oblique muscles and internal oblique muscles, and those are on 45-degree angles to each other so that they can compress in different ways. And then we have the transversus abdominis, which goes directly perpendicular to the long axis. So the transversus abdominis would kind of go this way. One oblique is oriented that way and the other oblique is oriented this way, so that you really have full coverage for whatever kind of movement you want to make. We have the rectus abdominis, which is from the xiphoid process to the pubic symphysis, so it goes right up and down that anterior abdomen. It is divided in the center by a line called the linea alba. It's a white line that is like a connective tissue in between the two muscle bellies of the rectus abdominis. And then transversely, it's divided by what are called tendinous inscriptions. So the muscle looks like this. That's our two muscles. So the linea alba would be straight down the center here. And then our tendinous inscriptions go across like that. So they're little tendons that make bulges. And so those are what actually make that sort of six-pack. If you have a six-pack in your abs, the tendinous inscriptions are what make sort of cut that muscle into those 6 different pieces. You could have an 8-pack. I had a bodybuilder patient who had an 8-pack. And then we have the diaphragm. The diaphragm is a large muscular sheet which divides the thoracic cavity and the abdominal cavity, and it is a muscle of respiration. So along with the external intercostal, contraction is going to allow inhalation, and then when it relaxes, it presses back up into the thoracic cavity to help deflate the lungs for exhalation. Here, we'll start up on this side. You have your external obliques, and you can see that they are on a 45-degree angle from the long axis of the body. These are our tendinous inscriptions, so that's what's giving us that 6-pack abs. The rectus abdominis muscle is here. I don't think you can see that very well. Let me delete some of this. All right, so the rectus abdominis is this whole muscle here. So it goes straight from the pubic symphysis up to the xiphoid process at the base of the sternum. The linea alba is this line directly down the center here. So it's where the two rectus abdominis come together. That's our linea alba. And then here you can see our intercostal muscles. They're hard to see, but they are in between the ribs. So you've got internal and external intercostals. They are at 90-degree angles to one another, and they are in between the ribs. So there's external are on the outside, internal are deep to those on the inside. And then here we've got the internal oblique muscle. So that is coming at an angle from the long axis of the body, and then we're going to have the transversus abdominis that would be covering that. This one you can take some time to look at. These are great. They're hard to look at because you have to really orient yourself to where you are, but they really show you the different layers of muscles that we have in the body. And so I would, once you're more familiar with the muscles, I would really encourage you to go back and look at pictures like this to get an idea of how the muscles are layered within the body. There's another one. So this one is at L3. So all of this would have all of your guts in there. The rectus abdominis is going straight up and down the front of the body. And then you've got these layers around either side where you have the transversus abdominis is the deeper layer, the internal oblique would be the center layer, and then the external oblique would be the outer layer there. So on here, I want you to know the scalenes, understand that the intercostals are between the ribs and help with respirations. And then the oblique muscles and the transversus abdominis are the three layers of muscle in the body wall. On this one, you should just know rectus abdominis is from the pubic symphysis to the xiphoid process. That one I do want you to know that origin and insertion, and to know that when that contracts, it flexes the spine. We don't often think of abdominal muscles affecting the spine, but they absolutely do. Next, we have our pelvic floor muscles. This is going to round out the end of our axial muscles. The whole purpose of the muscular layer in the pelvic floor is to keep everything in your pelvis in your pelvis. So it's supporting those organs, flexes the sacrum and the coccyx, and then controls the movement of material through the urethra and the anus. It's important that we have control over that, so we know that those are going to be skeletal muscle sphincters in those regions. In the pelvic floor, we have two different triangles, the urogenital triangle, which is in the front, and then the anal triangle, which is in the back. I would hope that at this point in your life, you could each look at those terms and figure out which one might be in the front and which one might be in the back. The urogenital triangle has a deep layer and a superficial layer. The deep layer is going to support the pelvic floor and the muscles of the urethra. The superficial layer is going to help support the external genitalia. And the deep layer of the posterior, the anal triangle supports, or the deep layers of the pelvic diaphragm are going to support the anal triangle. So we have pictures of female musculature and male musculature. And the main thing that I want you guys to understand is that even though the external anatomy in the female and the male is very different, Internally, our muscles are very similar. So both male and females have an ischiocavernosus and a bulbospongiosis. There are superficial and deep perineal muscles. Um, and then, so you can see the urogenital diaphragm is in the front, and then the anal is in the back. We also have a pubococcygeus and iliococcygeus. So those muscles are going to pull on the coccyx and the pubis. So in the male, still we have the bulbospongiosis, the ischiocavernosus, the superficial perineal. So it's all very similar. I didn't point out with the female the sphincters. So the sphincters are circular muscles that are surrounding, like this one surrounds the anus. This one is going to surround the urethra. And so those are skeletal circular muscles that give you voluntary control over elimination. So I'm not going to ask you what any of these muscles attach to. I just want you to be able to realize that when you see these muscles, that they are muscles of the pelvic floor. All right, that completes our axial muscles. So we're going to move on to appendicular musculature. So our muscles of our appendicular skeleton position and stabilize our pectoral and pelvic girdles. They allow for movement of our upper and lower extremity or upper and lower limbs. And they're divided into two sections, muscles of the shoulder and upper limbs, and muscles of the pelvis and lower limbs. You can look over this slide and the next slide for to come back and look at specific muscles, but I'm going to go past them so that we can learn individual muscles. All right, so our muscles of the shoulder and upper limbs position the pectoral girdle, move the arm, move the forearm and hand, and move the hand and fingers. So up top here, we'll just go through these. The levator scapulae is from the transverse processes of the cervical vertebrae down, so up here, down into the angle of the scapula. If both of those are contracted, they're going to extend the neck. If one is contracted, it's going to rotate the neck. Below that, we have the rhomboids. The rhomboids are rhomboid minor here and rhomboid major here. So remember, major means larger, minor means smaller. So the rhomboids are, when they contract, they bring the scapula back toward the spine. So they're going to pull the scapula in toward the spine like that. Over here you can see the triceps, so that's on the posterior surface of the arm. There are 3 different heads of the triceps, and the attachment at the olecranon process allows for extension of the elbow. The trapezius is this entire muscle here, and it has multiple different functions. So it can, if you stabilize the shoulder, you can laterally flex the head. If you contract both sides, you can extend the neck. You can also pull your shoulder back. You can pull your shoulder down. So this would pull your shoulder down. This would pull your shoulders together along with the rhomboids. And this would extend or laterally flex the neck. Let's skip over this one and we'll just go learn one at a time. So the levator we just talked about, I definitely want you to know that one. The pecs, we have pec major and pec minor. Those are on the anterior surface, and they are protracting your scapula or bringing your shoulder forward. The rhomboid we showed in the last slide, those are bringing your shoulders backwards, so they go from the spine to the scapula. You have two of them, the major and the minor. Serratus anterior also helps to protract the scapula. Subclavius helps to depress the shoulder and again pull the shoulder forward. And the trapezius we looked at in that last slide can elevate, retract, depress, or rotate the scapula. It can elevate the clavicle, or it can extend the neck. So the trapezius is a huge muscle that has many different functions. So muscles that move the arm, we have the deltoid, which is a large muscle over the outside of your shoulder, which is our major abductor. So it is bringing the arm up away from the body. And so that's our agonist. And then the supraspinatus is our synergist, and that assists the deltoid. So the supraspinatus is a rotator cuff muscle, and contraction of that does the first 15 degrees of abduction of your arm. And then once you get into that 15 degrees, the deltoid then takes over and does the rest of the abduction. Subscapularis and teres minor produce medial rotation at the shoulder. So if you are standing in anatomical position, medial rotation would be rotating so your thumbs are closer to your body, so your arms are pronated. So let's look here. So we have pec major on this side. So the pec major is this whole muscle here, like that, in a pec major. And then pec minor, we do not see on this one. The pec minor would be underneath this pec major. The deltoid muscle is covering the shoulder. That was our multipennate muscle that we talked about earlier in the lecture. On this one, we're looking at the back side. So we have the, well, actually, no, here, this is the biceps muscle. So that's one head, and this is the second head. So we're looking at the front side. Back here, we have the teres major, which is from the side of the scapula up to the humerus. And then this muscle is called the subscapularis, like that. And you can see the ribs are all cut away here. So the subscapularis is actually on the anterior surface of the scapula, between the scapula and the ribs. And it also comes out and attaches to the humerus. Our rotator cuff muscles, and remember it is cuff with F's, not cup with a P, rotator cuff muscles, they are involved in shoulder rotation as well as shoulder stabilization. So they can stabilize the shoulder while the larger muscles are moving the shoulder. We call them the sits muscles, S-I-T-S, to help you remember them. So it's supraspinatus, infraspinatus, teres minor, and subscapularis. And when we did the anatomy of the scapula, we learned that there was a supraspinous fossa on the posterior surface of the scapula above the spine of the scapula. That's where you're going to find the supraspinatus. The infraspinatus is in the infraspinous fossa. The subscapularis is on the anterior surface in the subscapular fossa. And then the teres minor is located on the edge of the, so let's see if this is our scapula. That's about as good as I can get drawing here. The teres minor comes off the side like that and attaches into the humerus. The infraspinatus is in this region. the supraspinatus is in this region, and then the subscapularis would be on that anterior surface. So here we're looking at the posterior surface of the scapula. So the supraspinatus is on the top in the supraspinous fossa here, and the tendon comes out and attaches to the humerus. The infraspinatus is these three bellies here coming off the medial surface of the infraspinous fossa. The teres major is this larger muscle down here coming off the lateral border of the scapula, and then the teres minor is a smaller muscle that is in between the infraspinatus and the teres major. We can also see the posterior portion of the deltoid here, and we can see this large latissimus dorsi. That muscle actually adducts the arm. So if the deltoid is going to abduct the arm, the latissimus is going to adduct the arm and pull it back down. So these ones, I want you to know where they are and what they do. You can know the approximate insertion and origin. So like deltoid is clavicle and scapula to the humerus. All right, that's the kind of stuff that I want you to know. Supraspinatus is in the supraspinous fossa and attaches on the humerus. All right, so you don't have to know all of these individual origins and insertions, but just to know what bones do they touch. That's important. One more important fact here is that the teres major produces medial rotation at the shoulder, and the subscapularis produces medial rotation at the shoulder. The reason being that the tendon of the teres major comes from the lateral side of the scapula, but it moves anteriorly to come around the medial side of the humerus and attaches to the front of the humerus. So when it contracts, it pulls on the anterior humerus and causes medial rotation. Versus the infraspinatus and the teres minor, oops, that's a little dark, which both do lateral rotation at the shoulder. And that's because those tendons are posterior and they attach laterally on the humerus. Instead of reaching under the front, they go around the back, so they do lateral rotation of the shoulder. Muscles that move the forearm and hand originate on the humerus and insert on the forearm. The exceptions are the biceps brachii and the triceps brachii, which do not originate on the humerus. Extensors are mainly on the posterior and lateral surfaces of the arm, and the flexors are mainly on the anterior and medial surface of the arm. To flex the elbow, the main flexor is the biceps brachii. That would be the agonist. It flexes the elbow, stabilizes the shoulder. It originates on the scapula and inserts on the radius. So it bypasses the humerus altogether, but it crosses over the shoulder and it crosses over the elbow. And so therefore it affects the elbow. In order for a muscle to affect a joint, it needs to cross over that joint. So the biceps attaches into the radial tuberosity on the radius, and it flexes the elbow. The brachialis muscle and the brachioradialis muscle both also flex the elbow. Those are synergists to the biceps. So here we can see the biceps. We have a short head and a long head. So this whole muscle, this whole muscle in here is the biceps with its two heads attaching down into the radial tuberosity. Oh, sorry, I'm trying to erase here. And then the brachialis muscle is at the elbow. It's a shorter muscle and it assists in flexion. It goes from the humerus down to the radius, and so it's going to assist with flexion. So that's a synergist. And then the brachioradialis also originates on the humerus and comes all the way down into the wrist, but it also assists with flexion at the elbow and lateral flexion down here at the wrist. Extensors of the elbow are the triceps brachii, which originates on the scapula and inserts on the olecranon process of the ulna. And then we also have the anconeus, which would be a synergist, and that opposes the brachialis muscle. So if we're looking here, we have the triceps back here, which has 3 origins. The third one is deep and cannot be seen. And then the anconeus, which is just this little muscle right in here that goes from the radius down to the ulna and assists with extension. So I would know all of these muscles. You do not have to know where each head is going to originate. Just know that the triceps is from the scapula to the olecranon process, and the biceps is from the scapula to the radial tuberosity. As we get down into the muscles of the forearm and hand, the names of the muscles begin to be very helpful in figuring out where they are and what they do. So let's take apart this first one. Flexor. So you know that first word flexor means this is a muscle that's going to flex. Carpi is the wrist. So we're going to flex the wrist. Radialis is on the radial side. So we're going to flex the wrist on the radial side. Flexor carpi radialis. Flexor carpi ulnaris flexes the wrist on the ulnar side. Palmaris longus is going to also flex the wrist, and you can, if you look at the word palmaris, palm, you know, it's on the palm side, which would be the anterior surface. So that's going to be the surface that flexes. On the extensors, we have extensor carpi radialis longus and brevis. So it's going to extend the wrist on the radial side. There's a long one and there's a short one. And then extensor carpi ulnaris is going to extend the wrist on the ulnar side. With these muscles, the flexors mainly originate on the medial epicondyle of the humerus, and the extensors generally originate on the lateral epicondyle of the humerus. So I would commit that to memory. The flexors originate on the medial epicondyle of the humerus, and the extensors originate on the lateral epicondyle of the humerus. We have muscles that pronate and supinate. So pronator teres and supinator originate on the humerus and the ulna, and they help to rotate the radius. Pronator quadratus originates on the ulna, and it assists the pronator teres. So the pronator teres and supinator are both at the elbow. Pronator quadratus is at the wrist. So I would just note that difference there. Pronator teres and supinator are at the elbow, and the pronator quadratus is down at the wrist. So if we want to look at those here, pronator teres is right here. Supinator, I don't think we can see here. Pronator quadratus is down here at the wrist. So pronator teres at the elbow, quadratus is at the wrist. Muscles that move the hand and the fingers are extrinsic muscles of the hand. They are extrinsic because the muscle bellies themselves are outside of the hand. They're all located in the forearm. Intrinsic muscles of the hand, the muscle bellies are located within the hand itself. So in these extrinsic muscles, only the tendons cross at the wrist. We have retinacula on either side of the wrist. So the flexor retinaculum is on the anterior surface, and that is like a tendon sheath. So it's a dense connective tissue that is holding all of those tendons in place. We have a lot of tendons that cross at the wrist and the muscles that act on the hand, and so we don't want those tendons to just willy-nilly flop around as they wish. So we have the retinacula, which keep them held right in place. So the flexor retinaculum is on the anterior surface and the extensor retinaculum is on the posterior surface. What can we see on this one? So here we're looking at the flexor muscles. And again, with these muscles that flex the hand and wrist, the names are really going to tell us what they do. So flexor digitorum is going to flex the digits. You can see that the muscle belly is in the forearm and only the tendons are crossing into the hand. And so when the muscle contracts and it pulls on these tendons, it is going to flex the fingers. So flexor digitorum superficialis is this muscle here, and it's superficial. It is closer to the surface. Flexor digitorum profundus is deeper, so it's down here underneath the flexor digitorum superficialis. All right, I think we're good here. Here's our supinator that we were looking for earlier. So that supinates the forearm. And then now the superficialis muscles have been taken away. So now you can see the belly of flexor digitorum profundus and flexor pollicis longus. So the pollicis is the thumb. So flexor pollicis longus is going to flex the thumb, and it is a longer muscle versus flexor digitorum brevis, which is a shorter muscle. I think we're good there. Now we have even more muscles taken away, and we're looking on the posterior side, so we're looking at extensors. So the anconeus up here, remember that was the one that is the synergist to the triceps and assists with extension of the elbow. And then we have extensor digitorum, which extends the fingers. So it has all of these tendons that come down and attach to the posterior surface of the digits so it can extend the digits or open the hand. Extensor digiti minimi, that is another one of my favorites. We have flexor digiti minimi and extensor digiti minimi, and what they do is they flex and extend your pinky finger. So that's just this little muscle on the outside that's going to go and attach just into the pinky finger. Abductor pollicis longus is going to abduct the thumb. Extensor pollicis brevis is going to extend the thumb. So you can see that all of these muscles are telling you exactly what they do and telling you their approximate size. So are they a big muscle or are they a small muscle? You can learn all of that just from the name. So with these ones, I really don't think you need to memorize these specific names, but what I want you to know is that they're all extrinsic, which means that they all, the bellies of the muscles are all lie within the forearm, and that they cross the wrist to affect the hand, and they basically, their names are going to tell you what they do. So extensor indicis extends your index finger. And then we have intrinsic muscles of the hand, and so those are muscles that move the metacarpals and the phalanges and that lie completely within the hand. So they do not have any attachments into the forearm, they are solely within your hand. So these ones, we have abductor pollicis brevis, so that is going to abduct the thumb, and it is a short muscle. So abductor pollicis longus was an extrinsic muscle, brevis is an intrinsic muscle. Abductor digiti minimi is going to abduct the pinky finger. Let's see, what else do we have? We have the lumbricals and the palmar interossei. So the palmar interossei means in between bones. So those are situated in between the metacarpals. And the lumbricals have the bellies within the hand, and then they go out and attach into the fingers. Opponens are going to, we have opponens digiti minimi and opponens pollicis. So opposition is bringing your pinky finger and your thumb together. So those muscles are specifically to do that action. And then on this one, we're looking at the posterior surface of the hand. I think it's strange that there are fingernails on this hand. I don't know, that creeps me out. But if you're looking at the dorsal interossei, so we had palmar interossei, and now we have dorsal interossei. So I believe the dorsal interossei abduct the fingers, and the palmar interossei adduct the fingers. These tendons are all tendons of extrinsic muscles. So all of those are tendons from extrinsic muscles. You can see them coming out of the wrist. But the intrinsic muscles here would be the interossei and abductor digiti minimi. I think that's about it. The rest of these are all tendons from external muscles, extrinsic. All right, that finishes the upper extremity. So we're going to move down to the pelvis and the lower extremity. And these are the last section of muscles that we're going to be learning. So the pelvic girdle is tightly bound into the axial skeleton. We want it to be that way because we need it to support us while we are walking. It permits small movement and does not have very many muscles. Muscles that move the thigh, we have muscles that move the leg, and muscles that move the foot and toes. So it's very similar to the upper extremity and muscles that move the shoulder, the arm, and the forearm. So here it's the thigh, the leg, and the foot and toes. So in the thigh, we have the gluteal muscles, which are on that posterior surface. We have lateral rotators, which are going to rotate the leg laterally. We have adductors, which are going to bring the legs together. And then we have the iliopsoas muscle. Our gluteal muscles are our posterior muscles in our hips. We have 3 of them. Gluteus maximus, which we can see here is cut away. You can see it on this side very nicely. Gluteus maximus is the most superficial and the largest of the muscles. Gluteus medius, which originates from the iliac crest and crosses down to the femur. And then gluteus minimus, which is the smallest muscle. So we have 3 layers of muscle covering our posterior surface, making up our buttocks. Deep to the gluteus minimus, or inferior to it, you can see the obturator internus, and that muscle covers the obturator foramen that we learned about when we learned about the coxal bone. We also have the tensor fascia lata, which works with the gluteus maximus and helps stabilize the iliotibial tract. We should come up with a picture Yes, and the next slide that's going to show us that. Okay, the next slide. All right, so the iliotibial tract is this tendinous tract that runs along the outside of your thigh. So it goes from your hip down into your knee, and there's the tensor fascia lata muscle, which is up here, is at the top of the iliotibial tract, and when it tenses, it helps to stabilize that whole iliotibial tract. So now we're going to look at lateral rotators. So those are, if you're standing, sort of bringing your toes out away from the midline of your body, that would be lateral rotation of your leg. So the piriformis muscle here is one of our main lateral rotators. This one is an interesting muscle. It originates on the anterior surface of the sacrum and then comes out to the greater trochanter. You'll notice a lot of these thigh or hip muscles attach into the greater trochanter of the femur. And the piriformis muscle traditionally, the sciatic nerve is underneath the piriformis muscle. So we would see the sciatic nerve exiting right here. So when the sciatic nerve or when the piriformis is tense, it can press on the sciatic nerve and cause pain into the lower extremity, mimicking a disc herniation. In 10% of the population, the sciatic nerve actually pierces through the middle of the belly of the piriformis muscle. And so they're at a much greater risk of having piriformis syndrome, which is that tension in the piriformis muscle causing lower extremity pain. Differential diagnosis between piriformis syndrome and disc herniation would be that piriformis syndrome traditionally is only going to cause pain to about the knee, whereas disc herniation is more likely to cause pain all the way down into the foot. Other lateral rotators, the obturator internus and externus, which are here. There's obturator internus right there. The gemelli, superior gemellus, inferior gemellus, so those are on either side of the obturator muscles, and then the quadratus femoris, which is here, and that is a short muscle that is attaching, let's see, right in through there, quadratus femoris. So our lateral rotators, the piriformis is the main one that I want you to know about, but just you can know the names of the other ones as being lateral rotators. And they mainly all are going to originate on the greater trochanter or the trochanteric crest of the femur. All right, our adductors, those are going to bring our legs together. We have the first three are named adductor, so you should be able to look at those and say, okay, those must adduct. So just knowing that they're in the leg, that's going to be your main thing. So adductor magnus is the largest one. Adductor brevis would be smaller, and adductor longus would be long. So here's adductor longus. Let's see. Well, that's the only one that we can see on this picture is adductor longus. Pectineus up here is a small muscle that does work to adduct the leg as well. And then gracilis is this thin muscle that runs along the inside of the thigh, and that also is an adductor. So just know the names of those muscles, and that they are, if it's going to adduct, you know that it's going to be on the medial side of the leg. You can't contract a lateral muscle and expect that it's going to pull the leg inward. So adductors are all going to be in the medial thigh, and three of them are named adductor, and then the pectineus and the gracilis are the other two. The iliopsoas, oh here, this is a better picture. So now you can see adductor magnus, adductor brevis, and adductor longus. So all of these on the medial side are your adductors. The iliopsoas are a hip flexor. It's made up of two muscles, the psoas major and the iliacus. So the psoas major attaches to the anterior surface of the spine, and the iliacus originates on the inside of the iliac fossa. And then they come together to form a single tendon that comes and inserts on the lesser trochanter of the femur. So when these contract, you can either flex your thigh up, or if you keep your thigh straight, like flat on the ground, they can pull and extend the spine. This muscle is, we find it often very tense with people who are having low back pain that hurts when they get up from sitting. So if somebody is, they're fine when they're sitting, but when they get up from sitting, they get a sharp pain in their low back, and after they walk a little bit, it starts to go away. That can often be a tension in the iliopsoas muscle, because it is that quick extension or that quick lengthening of the muscle fights against that and pulls on the anterior spine and jams those posterior facet joints together in the lower back. So our adductors we discussed, and then our iliopsoas. So I do want you to know that iliopsoas muscle. And then we have muscles that move the leg. We have flexors of the knee, which originate on the pelvic girdle, and extensors of the knee, which originate on the femur and insert onto the patella. Flexors of the knee are going to be on the posterior surface. So remember, when we are flexing the knee, we are bringing the foot closer to the buttocks, and so it's the posterior muscles that have to do that. So we have our hamstrings, which are three muscles made up of the biceps femoris, the semimembranosus, and the semitendinosus. So we can see the biceps femoris. Remember, biceps means two heads, so this one is the long head. And then we have the semitendinosus here, and the semimembranosus that you can see down here. So it's those three muscles there that make up the hamstrings. And then we have the sartorius, which originates on the superior to the acetabulum. That one, we can see just a tiny bit of it down here. And then the popliteus, which is in the posterior knee, which rotates the tibia to unlock the knee and allow for flexion. So we should hopefully see that in another slide. If I find it, I will point it out later. So our extensors of the knee are our quadriceps muscles. So we have vastus muscles and the rectus femoris. So the rectus femoris is the main extensor that is right in the center of the anterior thigh. So this is your rectus femoris here. And then we have the vastus lateralis on the lateral side, vastus medialis on the medial side, and vastus intermedius, which is going to be deep to the rectus femoris. So those four muscles together make up the quadriceps femoris, or the quadriceps muscles, and they're all inserting on the patella, and therefore then the patella is going to connect into the tibia via the patellar ligament. So pulling on the anterior tibia is going to cause extension at the knee. Here's a sectional view of the leg. So you see the femur back here, and then you've got the hamstrings on the posterior surface and the quadriceps muscles on the anterior surface. Then you have the adductors on the medial surface, and the, what do we have over here, vastus lateralis. So these are still quadriceps all over here. Muscles that move the feet and toes. We, again, similar to the forearm, we have extrinsic muscles where the muscles are located within the leg, and then we have intrinsic muscles that are located in the feet. So we have muscles that extend the ankle, muscles that flex the ankle, muscles that extend the toes, and muscles that flex the toes. We have 4 muscles that produce extension or plantar flexion at the ankle, and those muscles are going to be located on the posterior side of the leg because extension is pointing the toes down, and so we need to be pulling up on the calcaneus in order to point the toes down. So those muscles are the gastrocnemius, the soleus, the fibularis, and the tibialis posterior. So the gastrocnemius has 2 heads, and so it is this entire muscle here. This is what makes up the bulk of our calf muscle. And then on this, so that's our superficial layer. Over here on our deep layer, we can see that the gastroc has been resected, and now we can see that large soleus muscle that is underneath the gastroc. The gastroc and soleus come together to form the calcaneal tendon, which is also called the Achilles tendon. The fibularis group is going to be deep to this, and the tibialis posterior as well. So let's see if we can see that on the next slide. Tibialis anterior. All right, no, we can't see those on here either. So our muscles that produce plantar flexion, all right, so we already looked at these. Fibularis longus. All right, but you can see that they're on that posterior side, making up the bulk of your calf muscle. Here's our Achilles tendon, or our calcaneal tendon, shared by the gastrocnemius and the soleus. We already discussed that. Our ankle flexors are going to be located on the anterior surface, and they are the tibialis anterior is the main ankle flexor. So here's our tibialis anterior. It's anterior and lateral to the sort of that sharp shaft of the tibia. If you feel that bony ridge down the front of your leg, just lateral to that, there's a big muscle there. That is your tibialis anterior muscle. So something to keep in mind is when you are flexing your ankle, you're using anterior muscles. When you are extending your ankle, you're using posterior muscles. But in the foot, flexion and extension of the toes are opposite as they are in the hand. So anterior muscles are going to extend your toes, and posterior muscles are going to flex your toes. So our toe extensors, we have extensor digitorum, longus and brevis, and we have extensor hallucis. So extensor hallucis is going to extend the great toe. Extensor digitorum is going to extend the rest of the digits. So let's see. And then we have the extensor retinaculum, which is similar to the retinaculum in the wrist. However, we only have it on the anterior surface. We have a superior and inferior retinaculum, versus in the wrist, we have an anterior retinaculum and a posterior retinaculum. So an extensor retinaculum and a flexor retinaculum. In the ankle, we only have extensor retinacula. So here's our extensor digitorum longus, which you can see is a deep muscle in the on the anterior surface of the leg. So here we've got, you can see tibialis posterior down here. We have our extensor retinaculum, the larger gastrocnemius in the back. And then our toe flexors that are extrinsic, we have flexor digitorum longus, which is going to be on this lateral side, but these are all posterior. Flexor hallucis longus, which is going to flex the great toe. Fibularis brevis. And then our intrinsic muscles of the foot. So those extrinsic muscles of the foot, again, much like the forearm, the names are telling you where they are and what they do. So know which ones are extrinsic and which ones are intrinsic, but you can really learn a lot about them just by their names instead of memorizing every single one. So muscles that are intrinsic move the tarsals, the metatarsals, and the phalanges, and they originate and insert only on those bones. So they are only within the foot itself. They do not originate in the lower leg. So we have the, let's see, the abductor pollicis. We have dorsal interossei again, so in between the bones. Let's see, extensor hallucis brevis is an intrinsic muscle. The rest of those are all tendons of extrinsic muscles. And here we're looking at the underside. So this is the superficial view. So we've got the flexor digitorum brevis. So flexor digitorum longus is an extrinsic muscle. Brevis is an intrinsic muscle. You can see the entire muscle here within the foot. We have abductor digiti minimi, flexor digitorum brevis there, abductor hallucis. So those are all of our intrinsic muscles of the foot that are on the plantar surface. Also right here you can see resected is the plantar aponeurosis. So it's a long tendinous sheath that covers the underside of your foot and helps to give us stability with the arches in the foot. And then deeper down, we have the quadratus plantae down here. We have the lumbricals. You can see the lumbricals again are coming up like that, going from the metatarsals into the phalanges. So with these intrinsic muscles, again, just know which ones are intrinsic, which ones are extrinsic. You do not have to memorize all of the origins and insertions. And last, we're going to look at these leg compartments. So we have these fascial layers of connective tissue that are separating all of the different compartments in the leg. So we have the anterior compartment here, which has the tibialis anterior, extensor hallucis longus, and extensor digitorum longus. And what happens, so you can have something that's called compartment syndrome, which is where the muscles in one compartment grow too large for the connective tissue that surrounds them. So what happens there, and this actually happened to me in college, is when you exercise, your muscles increase in width, but the connective tissue cannot stretch enough to accommodate that increasing muscle size. So you end up with those muscles squeezing on the blood vessels and the nerves that are in that compartment, and it can cause your feet to go numb, and it can cause severe pain in your shins. So the treatment for that at that time, and they still do these, is a compartment release where they cut this fascia from your knee all the way down to your ankle to allow these muscles to grow without the compression of that fascia. So if you ever do get to see my shins, my tibialis anterior is huge because that fascia was cut and the muscle has been able to just grow to whatever size it would like to be. Doing very deep tissue work like structural integration type work or Graston technique can also be really helpful. In 1998, I was not educated about such things, so I opted for the surgery. These days, I would encourage people to try more alternative therapies prior to undergoing surgery. So that's the end of our muscle lecture. So do not memorize the innervations. We don't know the nerves yet, so let's not learn them. You don't need the specifics on the origin and insertions, just have an idea of what bones things are connecting to and what the action is. So if you were to contract a muscle, what effect does it have on the body? That's really what we're looking for this week. So enjoy the week, work hard, and I'll see you back next week where we are going to start our exploration of the nervous system, which is the last system that we are going to cover in A&P1. Have a great week.